So, good afternoon, and welcome to our Parent Guardian Talk series on common digestive issues in children. We are very grateful to have Dr. Eliana Shaw with us today. Dr. Eliana Shaw received her medical degree from Albert Einstein College of Medicine. She completed her internship and residency in pediatrics at the Children's Hospital at Montefiore, Albert Einstein College of Medicine. She went on to complete a fellowship in pediatric gastroenterology, hepatology, and nutrition at the Children's Hospital of Philadelphia. She provides board expertise in the care and management of children with various gastrointestinal diseases. She fosters skills in many unique subspecialties within the field of pediatric GI, including unsedated transnasal endoscopy using virtual reality goggles and providing individualized care to children with very early onset inflammatory bowel disease. She partners with families to navigate the diagnosis and management of a variety of clinical conditions. Dr. Shaw provides compassionate and empathic care every day for every patient and each family. Her goal is to actively listen to patients so that she can apply her skills and judgments combined with advanced technologies to provide a personalized approach that focuses on the unique needs of each patient. And in her spare time, she enjoys spending time with her husband and 3 children, biking and reading. So at this time, I will turn it over to you, Dr. Shaw. Thank you so much.
Thank you so much, Allison, for that lovely introduction. And welcome, everyone. Thank you guys for joining. And as Allison mentioned, a lot of this is going to hopefully be generalized knowledge to help you guys as already incredible parents. And kind of more specifics really depend on the exact situation. So the way it's set out is we kind of have like 5 main questions, and then we should have a lot of time for the Q&As. So to start with, how can I help my child poop? How often is normal? So there's a pretty big range. Normal can, some kids poop 3 times a day, even maybe 4 times a day. And sometimes kids poop once every other day. Once kids are on normal table foods, their stool pattern is like adults, and there is a range as to what's normal. Kids who go every 4 to 5 days almost always have pain or straining with the bowel movement. Usually they'll have really large bowel movements, and it'll hurt to push it out. Kids who go over 3 days, while that can be normal, they'll often drift into longer periods. So it's a sign that we're getting towards constipated. And really, any child that has pain during stool passage or lots of straining needs support or evaluation. And at the very least, the child should be treated with some changes in diet, as we'll go through, and some behavioral changes. Just wanted to add a little caveat if anyone has a newborn. This is different in newborns, especially in breastfed babies. It is absolutely normal for a baby to poop up, to go every 7 days, as long as it's soft and pain-free. Newborn babies can also go, 4-7 times a day. So really if we're talking about newborn infants before solids, the first few months of life, it is a little bit different. And I just wanted to go through a little bit straining in babies, or something called infant dyschezia. So sometimes babies, they're trying to poop. They look like they're struggling. They're pushing so hard. They're turning red. Grunting, straining, and this can all be normal in young babies. They're kind of learning really how to coordinate their stomach muscles and anus muscles, and they're learning to relax their anus. They've kind of spent 9 months of keeping it closed inside the uterus, and it's hard to pass a large stool while lying on your back with no help from gravity. When we sit on a toilet, we're upright rather than lying flat. So it's normal as long as babies continue to pass normal size stools every day. And as long, it's okay if they have some straining. Under 10 minutes of straining is normal in infants. So I just wanted to throw that out, because in the last slide I said straining is not good. So how can I help my child poop? So things that contribute to constipation include a high milk diet. Specifically, milk and cheese can cause a lot of constipation. And we see this actually very commonly at 12 months of age or 1 year, when you switch from either formula or breast milk to whole milk. And that is a very common time to see constipation. So usually what we'll do is we'll, limit it if the 1-year-old is drinking 24 ounces of milk, we'll cut it down to 16 ounces, 8 ounces. Milk is still very important for growth and for brain development, but if too much can really, really contribute to constipation. Low fiber diet can do this. Again, usually all these things that I'm going through alone don't necessarily cause severe constipation, but kind of all together can. So fiber's found in fruits, vegetables, whole grains, oats, and it works by keeping stools soft as well as bulky, so not teeny tiny and easy to pass. So a low fiber diet can cause hard, small stools. Low fluid intake. So this can also cause stools to be dry and harder to pass. It's rarely the only cause of constipation, but definitely can contribute. And then lack of exercise, not the most common cause in children, unless they're like really more confined to bed, wheelchair bound, but definitely can contribute. Withholding stools because of pain or power struggles. So this is definitely one of the most common causes. So many children, including my own, do not like to poop at school, and they'll hold it back. And then some other things. So babies are really, really smart. So let's say you have that 1-year-old I was talking about earlier, you introduce whole milk, their poops get really, really hard, it hurts. That 1-year-old is going to hold it in next time. And it's kind of a learned behavior that if it hurts, if it's hard, they hold it in. Or if they're at school, they don't like the bathroom, they're playing, kids hold it in a lot, and kind of the act of holding it in breeds more of a backup. This can really happen as well. So like I said, common times are when you introduce whole milk, any sort of change at home, so new sibling, new school, not wanting to use public toilets. And then another really, really common time is potty training, power struggle, just fear. And so these are common causes of constipation. And then the last one is slow passage of food through the intestines. So in some people, we just have food moves through a little bit quicker, and in other people, it moves through a little bit slower. So that can definitely contribute to constipation. So we mentioned some dietary changes on the last slide, increase water, decrease milk, increase fiber, increase exercise, but beyond dietary changes, medications and behavioral changes are often necessary in kids. And again, this can always be done in conjunction with your pediatrician. Osmotic laxative is just a fancy way of saying pulls water into the poop. So this works really well if the poops are hard. Miralax is the most commonly used osmotic laxative. It works great. It's not a stimulant, which we'll talk about stimulants in a second. Stimulants kind of push and induce squeezing of the colon and squeezing of the rectum. And they'll, those are when you think of X-Lax, Senna, kind of stimulate you to go. Osmotic laxatives are a little bit more gentle and really just make it soft. So in our babies who are having really, really hard poops or then holding it in, often use of an osmotic laxative is really helpful. Again, sometimes children who hold it in need a combination of both, and that's okay. And again, this is kind of to be done in guidance with either your pediatrician or with a GI doctor to come up with a bowel regimen. Most important is scheduled toilet sitting with a positive reinforcement plan. So what I mean by that is, I keep saying kind of over and over again that kids hold it in, kids hold it in. And even if we make it soft, even if we stimulate it, like kids are really surprisingly strong-willed and strong. And what works best is in conjunction with our medications is behavioral changes. So what I like to do is make a positive reinforcement plan, which, can be as simple as a sticker chart. And you get 1 sticker for sitting on the toilet, 2 stickers for pooping. And after a certain number of stickers, you get a prize. So what I have is scheduled toilet sitting, usually 2 to 3 times a day. The best time to have them sit on the toilet is about 10 to 15 minutes after a meal, because you have what's called the gastrocolic reflex, which just means that after you eat, food tends to move through and leads your body to try to, make room for more food by getting rid of whatever food is left in your system. So have them sit on the toilet, if the toilet is high up, have a stool so they have good posture, straight back, bent knees, and the feet should not be hanging down. They should be stabilized. There's a really good video that I actually didn't link, but it's called The Poo in You, if you look it up on YouTube. And they kind of go through the posturing as well. And then really just have the kids sit for 5 to 10 minutes. If it's a 4-year-old, usually I say up to the kid's age. So if it's a 3 or 4-year-old, they're not going to sit for 10 minutes. That's a really long time. But just to have them sit and try and poop, even if they don't feel like it. Sometimes things that also help are using bubbles, like blowing and blowing a pinwheel, because that helps relax your stomach and the anal sphincter as well. So that works. So again, it's kind of a combination of dietary changes, behavioral changes. If the poops are really, really hard, you should use an osmotic laxative to help soften it. If we're going a week without pooping, we're probably also going to need a stimulant laxative, at least temporarily. And then scheduled toilet sitting with the positive reinforcement plan is essential. Here's a little bit what I kind of mentioned, appropriate posture. In certain situations, if there can be leakage of poop. So imagine kind of your colon and your rectum are a pipe and there's a hard ball in the pipe, and then you just have like leakage of water on the side. So this is very common. It's called encopresis, which just means overflow and soiling of the underwear from chronic constipation. So in those situations, rather than just starting a medicine, I'll usually start a clean out first, which is a little bit miserable for a day or two, where you take a tremendous amount of laxatives, and that way you start fresh. In certain situations, you need rectal therapy, which are either enemas or suppositories. They tend to work really well by stimulating things from below, but are not super pleasant for a child. So I do like to limit and avoid those. And then not going to go into it. But in severe cases, there is surgical management. But again, if you're there, you should be seeing a GI motility expert. This is, not common at all to need surgical management. Beyond medications, talk to your pediatrician. Based on the severity, age of onset, like there are some things, should consider a GI referral. Functional constipation, meaning just run-of-the-mill constipation, no reason. We don't really know why it happens. Maybe it's a little slow, maybe some diet, accounts for 98% of children with constipation. The other 2%, so a pretty small number, include thyroid problems, celiac disease, spinal cord problems, cystic fibrosis, muscle problems, and something called Hirschsprung disease that presents in infancy. Again, these are not seen in most kids, just have run-of-the-mill constipation, but if it's refractory or really worrisome, then often, with guidance from your pediatrician, or sometimes the pediatrician with GI, will send a little bit more of a workup. But most kids most kids with constipation don't necessarily need blood work. But when it's refractory, we often get blood work to at least rule out some of the things, and then further workup based on the symptoms, age of onset, and exam. What are some concerns? So poor growth, refractory to a standard bowel regimen, abnormal poops as an infant. And when I say infant, I mean the first really month of life. A lot of kids get constipated 2, 3, 4, even 6 months of life, but really in the first month or two, constipation does kind of make us think to make sure we're not missing something bigger. Abnormal development in leg strength can also think of a muscle problem, a spinal cord problem. Kids with cerebral palsy often have constipation, and it's really just coordination of muscles. And then blood in the stool. So often with constipation, if you have a really, really hard, wide poop, because when poop just hangs out in the rectum and doesn't come out, it stretches and stretches and stretches. So you end up with these hard and wide poops. So you can end up with blood streaks from a fissure, which is literally just the hard poop cutting the anus on the way out. That's pretty common. But if there's more blood, more than just a streak, or even if there is streaks, that's a sign that you should talk to the pediatrician. Here's a little bit about the color of poops. So poops can be all colors of the rainbow, but really most normal poops are any shade of brown, yellow, or green. The only colors that are worrisome are red, black, and white. Red, we always worry about blood from either your lower GI tract, so from lower down, or if you have something bleeding really, really rapidly higher up. So if you're vomiting blood or have lots of bloody diarrhea, call your doctor right away. But we commonly see red blood from lots of different medicines, foods, Jello, licorice, lots of foods can cause, and different medicines with red and pink food dyes can cause your poops to be red. Next is black. So black also, black can be kind of slow digested blood from a bleed higher up. So if you see lots of black, it's called melena or tarry stools, call the doctor. But we also commonly see dark stools for medicine, iron, bismuth. So if the kid's taking Pepto-Bismol for any reason, or certain foods can do this. Beets can make your poops black. So, just keep that in mind. But, red, black, call the doctor. And then lastly, white. We see white poops in an infant less than 2 months. Call your doctor right away. It can be seen in a biliary blockage and liver disease. Again, can also be from medicines and foods. Unusual colors, green, purple, blue, are almost always due to food coloring or food additives. So green poops, come from really lots of different foods that you don't necessarily think of as green, but grape flavored Pedialyte, blueberries make your poops green, and then green leafy vegetables, spinach, all that will make it green. Stool color relates more to what's eaten really than to any disease. And in diarrhea, GI passage time is really, really rapid. So kind of like the opposite of what we were saying in constipation, where things are slow and kind of just hang out and slowly sit in your rectum. Everything's moving really fast, so it doesn't digest in the same way. So it'll often come out more similarly colored to the fluid that went in. Now kind of to pivot to abdominal pain. So what's causing the pain? So really a tremendous amount of things can cause abdominal pain, and the evaluation is, not something that I can say, with a one-line question. It really depends on the age of the kids, the location of the pain. Is it high up? Is it low down? The severity of the pain. Is it new? Is it old? Has it been going on for 1 hour? Has it been going on for 6 months? Does it last for 5 minutes? Does it last for 2 hours? Any vomiting, diarrhea, fevers, headaches, etc. So this is not an all-inclusive list, but from a GI standpoint, common things: constipation gives us belly pain, celiac disease, non-celiac gluten sensitivities, something called eosinophilic esophagitis, which I kind of think of like eczema of the esophagus, can present with kind of pain with swallowing and higher up pain. You can have a parasite infection. You can have peptic ulcerative disease, reflux, inflammatory bowel disease like Crohn's or ulcerative colitis, pancreatitis, something called gastroparesis. I'm kind of just listing an exhaustive list, but really so many things can give you belly pain. You can have surgical emergencies. So emergencies are severe right lower quadrant pain. Call your pediatrician right away. So the right lower belly is where your appendix lives. So if anyone has 10 out of 10 pain, not going away, screaming, crying, we need to see a doctor right away. Intussusception is kind of when the bowel telescopes on each other. You'll often see little kids with their knees, like babies with 1-year-olds with their knees up to their stomach, screaming in pain, gets better, screaming in pain, gets better. And then lots of non-GI things can give you belly pain. So pneumonias, you're coughing a lot, it can give you belly pain. A urinary tract infection, different rheumatologic diseases, ovarian torsion, trauma, diabetes, kidney stones, malignancy. So really lots and lots and lots of things can give you belly pain. I just wanted to go through a little bit about functional abdominal pain or irritable bowel syndrome, IBS. They're not quite the same thing, but functional abdominal pain is kind of the umbrella term, and irritable bowel syndrome does have specific criteria. But this is the most common cause of pain in children. So how I like to think of it is our brain and our gut are just not connected and not working together. And you get what's called visceral hyperalgesia or hypersensitivity, which means that kind of the nerves, and we all have thousands of nerves in our GI tract, they're kind of on overload. And teeny tiny triggers can cause symptoms such as pain, constipation, diarrhea, nausea, or bloating. And in these children, you can do a whole $1 million workup. You can do all the labs, all the imaging, endoscopies, colonoscopy, and they're all normal, but they're still experiencing very, very, very real symptoms of either pain, constipation, diarrhea. because the gut nerves are just really sensitive. And this often runs in families. Some people think of this as belly headaches, and it really just stems from the interaction between the brain and the gut, which can be abnormal. From a medical perspective, we treat this in many, many different ways. And I like to treat it in a multidisciplinary way, and include our social work team. And sometimes we don't specifically have GI psychologists at Hackensack, but we have wonderful local psychologists. But natural remedies such as peppermint, ginger, and this is all depending on what the specific symptoms are. But acupuncture, yoga, again, cognitive behavioral therapy with a psychologist, mindfulness, breathing can often work to reduce pain. We can use as needed medications such as hyoscyamine, whatever, it doesn't specific pains for belly cramping, constipation, kind of depending on what the symptoms are, treat the symptoms. And then for more severe cases, I can use daily preventative prophylactic medications. Again, this is very specific, but depending on what the actual symptoms are. What's best for the pain? So again, it really depends. And I think it's a hard question. I think most important is to speak to your pediatrician at first, kind of figure out if this is something that needs a GI referral with your pediatrician. And it really just depends on how bad it is, how long it's been going on, and any other associated symptoms. So here's another just example. Kids common complain of higher up pain, chest pain, epigastric pain with regurgitation. So the feeling like food is coming up. If this happens after eating or at night, we'll often think of gastroesophageal reflux disease or GERD reflux. And we can, again, treat this in a variety of ways, depending on the severity and the symptoms and the patient. So in some kids, we use acid blockers. I always recommend lifestyle changes. So smaller, more frequent meals instead of eating gigantic meals. Avoid eating right before bed in kids who always have nighttime pain after lying flat, because reflux is essentially when you swallow food, it goes down your esophagus into your stomach. And then there's this sphincter or kind of door called the lower esophageal sphincter that opens to let food in to the stomach and help it go through. And then it's supposed to close when we're done swallowing, but it can transiently open, leading to reflux. So in that case, gravity and lying flat are not super helpful. So if your stomach is full of food right when you go to bed, more likely to experience symptoms. Carbonated drinks just add air to your stomach. And then some other common triggers of reflux: chocolate, caffeine, greasy foods, spicy foods, acidic foods. And again, really depends on the patient. I don't like to eliminate all food groups, but kind of just to pay attention of what causes the pain. And I think food journals and journals of symptoms always help. Similarly, to avoid eating before bed, you can also elevate the head. Exercise also can cause transient openings, so avoid eating large meals prior to exercise. And then if a child is overweight, often losing weight does help. Is there something wrong? So, a lot of kids experience belly pain, and a lot of kids experience, IBS, which I was discussing previously. And, I have a test, I have a belly ache, and not always is there something wrong, but red flags, reasons to definitely talk to your pediatrician and not wait, is poor growth, weight loss, drop in percentiles, and height and weight. So kind of we were growing beautifully at the 50th percentile, and then we dropped down. It's always something just to seek a little bit, to do a little bit more of an evaluation. And again, it depends on the whole constellation of symptoms. Severe abdominal pain. So like I was saying, appendicitis, 10 out of 10 pain, screaming, crying, can't move, like that needs to be seen more urgently. Bloody diarrhea. And I mean, a lot of different infections like Shigella, E. coli can give you bloody diarrhea. But I think definitely worthwhile to see the pediatrician if you're having significant amounts of bloody diarrhea or any bloody diarrhea that persists for more than a day or two. You should absolutely be seen. Nocturnal bowel movements, which means pooping at night. Again, if it happens once, twice in the setting of an infection, definitely can happen. But if it happens more commonly, you should see a doctor. Recurrent vomiting. So vomiting frequently is not normal. Again, some kids vomit when they're sick. Some kids vomit, you can have a cough-induced vomit. So a lot of kids with asthma, when they get full of phlegm, they'll cough, cough, cough so much it'll trigger vomiting. But to have vomiting, constantly with eating, sporadically, or anytime you vomit red or bright green, those are always call the doctor. And then if you're unable to tolerate fluids by mouth, so every time you drink something, you vomit, we're worried about dehydration. And then another red flag reason to talk to your doctor is recurrent fevers when you're not sick. So, anyone with a kid in daycare knows they have a cold, they'll get sick once, twice a month and have a fever here or there, and that's okay. But if they constantly have fever when they're not otherwise sick, that would be a little bit more worrisome and reason to see your doctor. So now, I know I just said a lot really quickly, so I am going to pivot into the questions.
Thank you so much, Dr. Shaw. That was very helpful and informative. So we do have some questions that were submitted ahead of time. So let's see. The first question is, it's the two parts. So how do you tell when an autistic child is constipated, and constipation issues with a child on autism spectrum, and their blood work is showing all negative findings?
So I guess I'll answer the second part first. So like I said, blood work in 98% of the kids with constipation, blood work is going to be totally, totally normal. So that does not mean they're not constipated. They can definitely have symptoms of constipation of hard or infrequent poops with normal blood work. So it just means they fall under the category of functional constipation, most likely. Again, there's lots of motility testing and other things, but and that would be something I would talk to the doctor about to make sure we're not missing something bigger. But in a kid with autism, very similar to a kid without autism, constipation is extremely common. It's a little bit harder in kids who are much pickier eaters, not necessarily verbal and can tell us what's going on. It's a little bit harder, but and it's also sometimes harder to do some of the behavioral modifications. But in a kid with autism, the same way you can tell if they're constipated as another kid by looking at their poop patterns, seeing how often they poop and what their poops look like. There is a higher rate of encopresis or leakage of poop with kids with constipation. So I explained it a little bit previously, but again, when poop kind of goes through, so we eat food, it goes through our digestive system, through our small intestine, and then the job of the colon, which is kind of this like upside down U, it's really, to simplify it, to reabsorb water and to propel poop forward. So when it gets to the rectum, which is the end of the colon right above the anus, it stretches and it sends a message, time to poop. And like I talked about earlier, lots of kids are like, yeah, great, let's poop it out, and they push it out. Whereas other kids hold it in. And when you hold it in, it gets more stretched, and then you can end up with these wide poops. So I think with a kid with autism, similar to any other kid, you can get wide poops, hard poops, and the same method as I was mentioning before needs a combination of Miralax, as well as sometimes a stimulant laxative and lots of behavioral changes. So it does tend to be a little bit harder with the behavioral changes, but very similar to a kid without autism, just a little bit more common.
Okay. And another question, with autism, how does it affect children's eating? They may be a highly sensitive to smell, sound, taste. Are you aware of any of those issues that may affect their eating?
Yeah, I think in general, kids with autism or really any sensory changes, sometimes it is tricky. And though in kids with specific food aversions, picky eating, again, unrelated to constipation, it can be challenging. And often what helps is kind of a multidisciplinary approach. So working with your pediatrician, if there's concerns for poor weight gain and malnutrition, with a GI, a dietitian, and often feeding therapy and occupational therapy really help a lot with textures, and feeding therapy specifically with introducing a different variety of textures, tastes, and smells. And again, that's with really any child with sensory issues as well as autism. It certainly can be a challenge, but it really helps to work with a multidisciplinary team depending on the severity.
All right, thank you. The next question is, even with a high fiber diet, plus Miralax and a herbal Swiss Chris every day, the only way their child goes is when they give a suppository. So how often are suppositories okay?
So I think it, again, depends on the age of the kid. And, it's a pretty difficult question to answer. I don't like giving frequent suppositories. Sometimes though I see kids, with cerebral palsy who do have really low tone and poor muscle coordination, and they do need rectal therapy from below. And in those kids, again, sometimes surgical management or high colonic enemas, which are basically a red rubber that goes high up, as opposed to just a tiny little glycerin, tend to work really, really well. But in a kid without any muscular changes, muscle problems, and otherwise healthy, I don't like to use frequent suppositories. So in this type of kid, I would definitely see your doctor and, see a GI, A, to make sure we're not missing something, B, to make sure we're appropriately dosing the medicine, because if the kid is 7 years old, 8 years old, and taking a teaspoon of Miralax instead of it comes in a cap, and one cap is essentially 4 teaspoons approximately. So we often see kids on teeny tiny doses of Miralax, on Miralax for a week, on, we can up the dose. Sometimes a 7-year-old needs half a cap, sometimes a 7-year-old needs 1 cap, sometimes they need 1.5 caps. And this is when we start to, again, do more of a workup, make sure we're not missing celiac or thyroid disease or anything else that could be contributing. And then sometimes it just takes, again, a combination of a stimulant laxative such as X-Lax, Senna, frequent toilet sitting, scheduled toilet sitting, and more higher doses of Miralax. But if not, I mean, this is where you need to, I can't really give specific advice, but see a GI, and a GI can, assess with the surgeon. If there's a muscle problem, we send you to pelvic floor physical therapy or biofeedback with a motility specialist. We make sure there's no issues with the muscles or the nerves in the colon. They sometimes do anal Botox. There's a lot of things we can do, but in general, I don't like using suppositories more than once a week, once a month. Even that I don't love doing. It just means we need to tweak your bowel regimen, tweak the toilet sitting, and do a little bit more of an evaluation to make sure we're not missing something. So at first, I would definitely see the doctor, get an exam, including a rectal exam, and then kind of go from there and adjust the medicines and regimen. And then if needed, like I said, get more of a workup to make sure we're not missing something. But a lot of the time we see just not adequate dosing, and tweaking the doses as well as scheduled toilet seatings make a huge difference, but sometimes they don't. And then we do have, like I said, stronger meds, different things we can do. So there's a lot of different things, but those ones, it just really depends on the child, the physical exam, and the situation.
Thank you. The next one, are there any natural supplements besides Miralax or laxatives in general?
So there's a ton, and if you look it up, if you Google it, there'll be like really unlimited. So really just anything with high fiber. So beans, fruits, especially the skin of the fruit, oat products, whole grains, vegetables, prunes. There's lots of different prune lax products. So some of those prune lax are really prune mixed with senna, and they're not really natural. So it just depends. Probiotics can also help. So there are a lot of natural different teas that can help. But it really, again, depends on the situation. But yes, prunes are great. Prune juice is great. Pear juice.
Okay. The next one, is there such thing as prebiotic? Is it important in our diet? Is it advised to do both prebiotic and probiotic? Can you please explain the difference?
So probiotics are literally bacteria. So they're beneficial bacteria. So in our GI tract, we have tens of thousands. It's our gut microbiome of living microorganisms in our bodies. And there's good ones and there's bad ones. And a lot of the bacteria in our body are made up of what we eat. And there's a lot of research going into the microbiome, but kind of probiotics are beneficial bacteria. Again, living microorganisms, and you can take them in pills or chews or liquid, and they restore balance of the microbiome and gut flora. Prebiotics are essentially, they're not living, they're not bacteria, they're plant fiber essentially that help the gut bacteria grow. So they're kind of like prebiotics are food for the probiotic, is how I like to think of it, if that makes sense. Prebiotics are essentially fiber, so they definitely help with constipation, but with anything, eating too much fiber can make you super bloated. Probiotics, I think, are fabulous. There's limited data for their use, but anecdotally, I find they work really well in certain conditions. The only thing I would caution is, again, a probiotic is a live bacteria. So if you're immunocompromised, if you had a liver transplant, if you are a very, very premature baby with a central line of some sort, then I would probably not use a probiotic. But in general, they've been shown to help in IBS, mixed reviews for constipation. After antibiotic use, again, is pretty mixed, and there's not great data, but anecdotally, I've seen it help.
All right, thank you very much. The next one, and I don't believe you covered this, but how long can a child stay on Miralax for constipation issues? Is there any long-term implications for staying on this medication for long periods of time?
I love Miralax. It's not like FDA approved for long term, but there's a lot of bad rep and bad publicity for Miralax. There's Mothers Against Miralax, and this was all based on this false study. And they have since tried to do other studies where Miralax is to test the Miralax, and it's not absorbed into the bloodstream. So you can be on Miralax for years and years, and if it's helping, I don't see any downfall. Obviously, that's a decision that needs to be made on a personal level as a family member. But from my standpoint, you can be on Miralax for more than a year, no problem.
Okay, the next one. If a child has a diagnosis of gluten intolerance that may turn into celiac disease, how do you know when it's the right time to retest for celiacs?
So I'm not really sure how to answer that. So I guess to take a step back, so gluten or gliadin, celiac disease is specifically when gliadin causes inflammation in the duodenum, or the first part of the small bowel. And this can present with a variety of symptoms, including low growth, short stature, so not growing well in height, not growing well in weight, bloating, diarrhea, constipation. It can give you anemia because you're not absorbing iron well. Vitamin D deficiency, though honestly, everyone in New Jersey has vitamin D deficiency because we're so north without the sun. But so we test and family history of celiac. So we test for celiac for a lot of reasons. So celiac disease specifically, you have antibodies. So when you test the blood work, you'll have some sort of sign in the blood work. And then in North America, we confirm it with an endoscopy. Now, sometimes those can be negative, and you still have symptoms of every time you eat gluten, you get bloated every time. So that is what we call that's what we call a gluten sensitivity and not celiac. In terms of when to retest, I think it really depends on what the symptoms are, if there's a family history, how growth is. It really just depends why the initial celiac testing was done. But the only thing I do caution is you have to be on a gluten-containing diet when doing these tests. So for the blood test, at least 6 to 8 weeks of real gluten use, like approximately a piece of bread a day, or for an endoscopy, at least 2 weeks and again, I would not do an endoscopy first. But if you're getting an endoscopy for some other reason, and the question is, are they celiac? You need to be on a gluten-containing diet. The only other thing that I'll just mention real quick is there's also a gluten allergy, and that's like an IgE mediated allergy is when you eat gluten, you get hives, rash, trouble breathing, like the same thing you think of with a peanut allergy. So that's kind of the third category. So I don't know if that answered it, but it really depends on why you were testing it in the first place. And if it's for a family history, then I would test pre-puberty annually or every other year at least. If it's for symptoms, if the symptoms get better, really just depends on when you want to reintroduce gluten.
All right, thank you. So does taking daily magnesium help with constipation at all?
So depends the formulary, but yes, there's a lot of different types of magnesium. Magnesium oxide is a osmotic laxative. So I know I only mentioned Miralax, but that is definitely an option. Magnesium citrate can be a stimulant. So I know there's a lot of different supplements, that people use with magnesium for a variety of reasons, whether it's to help you sleep or to calm you down, but I would just connect with your pediatrician before starting them. Because some can be osmotic laxatives, stool softeners, which are great, and others can be stimulant, which are also great, but it just depends on why you're doing it. But yes, magnesium can absolutely work to help you poop.
All right, great. The next one, besides fiber and water intake for constipation, can you name a few exercises that could help? They've tried raising the legs close to the chest, but at times it works and sometimes it doesn't.
Again, I think it really depends on the age of the child and what the issue is. Like those tend to work with babies. It really depends. Like if the poops are really, really hard, then I would make them softer to help get the poop out and sometimes use a stimulant laxative. There again, kind of to simplify it, you can do testing, something called manometry, which is motility testing to literally test. So usually when the anus, when the rectum stretches, you get a message sent to your brain, time to poop. And there's two sphincters. There's an internal sphincter, so that relaxes, and then there's an external sphincter, and you have to really like push to open it. And sometimes when kids are pushing, it tightens. So they really just don't know how to push. So in those situations, you really do need either biofeedback or pelvic floor physical therapy. And those are not exercises that as a GI, I honestly can teach. But if the issue is with clenching and not pushing properly, pelvic floor physical therapy can really help.
All right, thank you. So the next question is, they are interested in the medical aspect of the delayed toilet training due to history of severe constipation. Is there any strategies that you might have for that?
So similar to what I was saying earlier, like if the poops are really, really hard when it gets to the rectum, a kid is smart and is going to hold it in. And often toilet training, kids can have a power struggle at first, and then it becomes hard and they hold it in. So I recommend waiting on toilet training until the poops are soft. So whether that's a month, 2 month Miralax, like when we're in a good place. So sometimes, people like to train their 2.5-year-old, 2-year-old, and that does work for some kids, but for a lot of kids, it can lead to withholding. So if it does, and then you have hard poop and they're freaking out, I recommend definitely pausing, taking a step back, waiting until they're ready, and waiting until their poops are soft and painless. Because if their poops are really, really hard and hurt, they're not going to want to go on the toilet. And even in the diaper, they're not going to want to go, and they're going to hold it in. So before toilet training, I'd make sure poops are soft and painless. And then there's, again, lots of behavioral things that we can do depending on the kid. If the poops are soft and then we're toilet training and they're still afraid of the toilet, whether it's starting to just poop in a pull-up in the bathroom, and there's lots of ways to get kids to go on the toilet. But I think this specific question was not that. It was really, I do recommend waiting.
Okay. The next question is, are you familiar at all with the Mommy's Bliss baby constipation ease plus prebiotics?
So Mommy's Bliss is a brand, and if you Google it, there's like a million different types of ones. So I'm not sure specifically which one. Some of them have simethicone, which works. It's Mylicon, simethicone works really well for gassing, bloating. Some of them have probiotics, which can help definitely with constipation or struggling to poop. So I believe that Mommy's Bliss, again, makes a variety of different ones. Some of them work great and some of them less so, but I think it's just important to look at which specific one you're using. So again, if you are looking for like a fussy, gassy baby, to do the one with simethicone. And if you're looking for a more constipated one, the one with a probiotic. But again, they all kind of look similar, but there are differences.
Okay, perfect. The next question, what age can an infant take on solid food? And if the person cooks at home, for example, pureeing the fruits and vegetables, is it still necessary to buy commercial baby food? I'll start with that.
So usually we say 4 to 6 months, and it depends on the situation. But this is not premature baby with good head control. 4 to 6 months. A lot of people are very excited to start feeding, but at 4-month-old, the baby is just not ready, and that's okay. Really, before one, the goal of food is really to learn to eat, and it does have a variety of other benefits, including it helps with reflux a lot of the time, and some kids really, really love food. So usually by 5 months, kids are ready, but some kids are very excited at 4 months, and that's totally fine. And some kids aren't ready till 6 months, and that's also okay. So really between 4 to 6 months is when we recommend it, depending on the child. And again, they need to have good neck control so so they're not at risk of choking. In terms of the homemade food is totally wonderful, and it's whatever works for your family. And totally your preference, and that's all great. The only thing I do recommend is if it's your first child, buying at least one stage one, like literally just one jar, so you can see the consistency, because when you're starting with the teeny tiny baby, it's very liquidy and much more liquidy than people think. So if you start with something thicker, they may be totally fine, or they may gag. And again, different babies have different levels of a gag reflex, but a lot of babies will gag on chunky foods before 7, 8 months. And so to avoid that, if you're making it at home, just to buy at least one to see really how smooth and liquidy it is.
Okay. The next question is to cut down on lactose intolerance. What is better, breast milk, Lactaid whole milk, or Lactaid 2% milk?
It really depends on the kids. So just to take a step back, so lactose is the sugar in milk. It's pretty uncommon for a baby to have lactose intolerance, but some do. Definitely you could. Under 1, though, most kids have milk protein intolerance. So that's, again, the protein, not lactose, which is the carbohydrate or the sugar. So a milk protein allergy baby can either take breast milk if mom is eliminating dairy and or soy, depending on the situation, or a formula that's either hydrolyzed, which means broken down, or fully amino acid based, which means they really break down the protein to the teeny tiny building blocks. When we talk about lactate milk, so we introduce milk as opposed to formula at the age of 1. So again, it really depends on the situation. So a lot of families buy lactate milk because another family member is lactose intolerant. And again, that's usually presents not in infancy, but a little bit older, bloating, diarrhea, pain after dairy. And lactate milk is great for that purpose. So lactose is the carbohydrate, and lactase is the enzyme that breaks down it. So people who are lactose intolerant are missing that enzyme that breaks it down. So that's why they get the pain. So essentially, lactate milk is just milk with the enzyme added to it. So that's also what lactate pills are. So you can also use oat milk, soy milk, like there's really lots of options. And in terms of 2% versus skim, if it's a baby less than 2, then I always do whole, full fat. Once you're over 2, then it really depends. But usually I'll reduce the fat content. So in general, like you can switch a 2-year-old child, 3-year-old child to 1% milk. They don't need full fat milk anymore if they're growing normally. If they're underweight, I do continue whole milk. If they're overweight, definitely switch to skim milk. So I think it really depends on the situation. But again, oat milk's great. There's lots of pea protein milk, soy milk. In general, the nut milks are a little bit lower in fat. So in the first like 1 to 2 years, I don't usually recommend like almond milk.
Okay. And is it, what are your thoughts on like lactate milk with a milk protein, or the lactate cottage cheese for some dairy protein, or are there other
I
things?
think it really depends on why you're doing it. So, like I said, if it's for a milk protein situation, then you need in a newborn to 1 year, then usually you avoid dairy. If it's for lactose intolerance, I think the question is, why do we think they have lactose intolerance? Which again, usually is pain, bloating, diarrhea after dairy, which you absolutely can have. Sometimes you can even temporarily have this after an infection. And so again, lactase is the enzyme that breaks it down. So unfortunately, the best way to measure it is with an endoscopy, which is very invasive, or not very, but it is invasive, requires general anesthesia. And we don't routinely do it for lactose intolerance, but that gives you a level of how much you have. So some people have none, and some people have a medium amount, and some people have a lot. So in people with a medium amount, they can sometimes tolerate certain cheeses, certain yogurts, but when they try to drink milk or have ice cream or a milkshake or something with a lot, then they'll have symptoms. So I really think it depends on why you're going lactose free. If you're trying to fully eliminate lactose, you just need to fully eliminate it. If even a small amount gives you symptoms, or you can take lactate pills, or some people, again, can tolerate things with less dairy in it, just small amounts. So I think it really depends on why you're doing it.
Okay. I'm keeping an eye on the time because we're almost at time. So probably have time for 1 or 2 more questions. This one is, what is the best way to keep the digestive system healthy when the child is G-tube dependent?
So I think it depends on the situation, but there's a variety of different formulas. Most of the formulas are nutritionally complete. Some of them are food-based, some of them are like whole food-based, blenderized whole foods. Some of them are truly just formulas. Some of them have fiber in them. Some of them have more fiber, some of them have less fiber. So I think it really depends on what the symptoms are. If there's constipation, we can often switch to a formula with a more fiber in it. We can also add a little bit more free water sometimes. You can also do a probiotic. So I think it really just depends on, if we're exclusively G-tube fed, or if we're also taking in foods, and what the other symptoms are. Some people who are G-tube fed, if we take all liquid in, you can sometimes have all liquid out. So it really just does depend on what the specific issue is. But if the issue is constipation, you could switch to either a sometimes whole food formula, but sometimes that makes it more constipated. It's often trial and error, but some of them do have higher fiber content in them, which work really well.
All right. So is it common for children to have constipation and gastric reflux disease? Is there a correlation between the two?
They're both extremely common. To be honest, I'm not 100% if there's a correlation. Kids tend to be less hungry and their stomach's more full when they're constipated. So perhaps that could lead to more reflux if your stomach is more easily full. But to be honest, I'm not 100% sure about that. If the issue is a true motility one, meaning things move slowly, then yes, they're absolutely correlated. But in general, they're both very common. I'm not 100% sure on the answer to that one.
All right. Well, thank you so much. And thank you all for joining us today and all your great questions. I found it very helpful and informative. So So please watch your email for an evaluation of the program. Please take the time to fill it out. We want to hear from you, and also let us know if there's other topics of interest. The link will also, for the recording, be in your email. And to kick off 2024, we'll have another Parent Guardian talk series on January 25th, and it's on My Child Cannot Concentrate. And then on February 29th, we have one on coping with loss. So if you want to find out more information about those programs and other programs that we offer, you can visit our website or call 1-800-560-9990 to register and find out more information. So again, I thank you, Dr. Shaw. This was very helpful and informative, some great information, and I appreciate you all taking the time to join us for this program. So I hope you enjoyed the rest of your day, and thanks again for joining us.
Yeah, thank you. And very quickly, ripple milk is great, depending on the situation. I see that as a quick, easy question. Okay, yeah, thank you all for joining. I appreciate your time.
Thank you. Have a good day.